Well, welcome and thank you for joining this first of 3 roundtable discussions that I'm co-chairing with Chris. I'm Hannah Farrar, Chief Executive of CF, a management consulting and analytics company dedicated to improving health and healthcare. I hope you have a cup of tea handy and that you can take the next hour to sit back and enjoy the discussion we have in store. It's an opportunity to reflect, to think, and I hope to provide some reassurance in your own approaches, but also perhaps some new ideas as well. The plan for the next hour is that I'm going to provide a short overview of our roundtable series, hopefully entice you to join the other two if you haven't signed up already. Chris is then going to introduce our wonderful panelists and start us off with some questions. At the end of our kind of pre-planned questions, we're hoping that you will ask some questions from the floor. And if you fancy doing that, or you just fancy remarking on what people are saying, please do put it in the chat so that you can actively participate in what we've got in store. So let me start by telling you a little bit about our roundtable series. So COVID-19 has introduced unprecedented challenges to health and care, unlike anything most of us have experienced before. During this time of crisis and uncertainty, leaders must remain focused on their mission and adaptive to the ever-changing environment that we're facing. Feels like it's changing on a daily basis at the moment. But rather than bracing for temporary hardship, I think the sprint is well over and we're all aware that we're in for a marathon. We can't just wait for normalcy to return. So we've got to prepare for a permanent shift in how to plan, prioritise and deliver better health and care services. So to equip leaders with relevant, timely insights and a robust forum for discussion, CF is hosting this 3-part roundtable series that features prominent panellists, which Chris and I are going to enjoy having some conversations with. The panellists themselves have first-hand experience being leaders in the health and care sector. So we want these roundtables to tackle specific ways that leaders and organisations have to respond to, manage and anticipate the changes ahead. As I said, I hope it's an opportunity for reflection and also for learning. So Chris, I think you're going to lead us into today's conversation.
Thank you, Hannah, and I'm very pleased to be working with you today and with our excellent panel. Excited to hear their views on one of the big topics that's arisen out of the NHS response to COVID, the impact on the workforce, lots of positives, but also, as I'm sure we'll hear, some real concerns about where we are and where we might be going with the resurgence of COVID. And we have 3 people with us today who will be illuminating our thinking about the next stages and also the lessons from recent weeks and months. I have long CVs for each of them, but in the interest of time, I'll just do very brief introductions. Martin Marshall is the chair of the Royal College of GPs. Welcome to Martin, also a practicing GP in East London with a stellar career covering many organisations, many aspects of health and care policy, and obviously with a particular expertise in primary care. Then secondly, welcome to Ben Morrin, who's currently on loan from UCLH, where he's the workforce director working with NHSE and I across London. And last but certainly not least, Joe Andrews, working at Farrar, a healthcare leader coming from a clinical background, working with the NHS for many years, and very much interested, as you'd expect, in clinicians' clinical leadership and their contribution to the workforce. So we'll be hearing from all 3 of our panelists, and we'll also later on be hearing from you, our audience, on the issues of interest to you. I'm going to kick off with a question to Joe about staff well-being, Joe, and motivation. And we've obviously experienced a huge outpouring from the public of gratitude and support for what the staff in health and indeed social care have done during the last 6-7 months or so, but we're hearing now too the impact that's having, the negative impact of fatigue and perhaps the impact on staff morale too. So what do you think healthcare leaders should be doing to support and motivate the workforce?
Thanks, Chris. I think my starting point is to challenge the premise of some of the question, which, sorry, it's a dodgy political manoeuvre, but I think people's experience of the past 9 months has been so enormously variable. It's really quite dangerous to kind of categorise that as a single thing. So for, yes, some parts of the health and care system, teams did come together and work very effectively. But we need to acknowledge that for others, actually, the experience was quite different. So some clinicians found the past period deeply frustrating because they weren't able to deliver the services that they would normally choose to deliver and weren't able to be used in an effective way to support the needs of the first wave. Some people have been shielding, some have been working from home. The impact on our ethnic minority workforce has been significant and different, and that is a source of considerable distress. And on top of all that, these people, as well as being sort of workers in health and care, are people in their own right, with their own backstories, their own challenges that they've been managing in their personal lives. So everybody's experience is very, very different. And the context within which they've been working may be, their normal environment. So for critical care colleagues, yes, it was extreme, but actually it's part of what they normally do and an extension of that. For some others, they were thrown completely into an alien environment with variable levels of support. And I think in some ways the group I feel most concerned about is people outside of the health system but working in care homes and providing domiciliary support, for whom the sense of burden of care that they're trying to provide under extraordinarily difficult circumstances, how that can't have had a personal impact on them, I don't know. So taking all that as the starting point, I think leaders' responsibility in the first instance is actually to go and listen to those stories and to understand that everybody's experience has been different, and to tap into those experiences and ask the question, so what needs to be different this time? What can we do this time that will make your experience different? And recognise that actually everybody who works in health and care is bound together by a common desire to help. And part of leadership's role under those circumstances is to facilitate that in the best way possible and try and understand what's got in the way. I think there's a need to plan early so that staff aren't stretched to breaking point, either physically or psychologically. The evidence is absolutely there of the mental health impact from the first wave. We need to make sure that we're not doing that again and recognise that the way we did things last time resulted in some staff being underused, others being pushed to burnout. But in order to make fully use of all staff, we've got to make sure that they have the training and the support that's needed, and that they're able to do what we're asking them to do without an undue impact on them as individuals. And I think we need to recognise the fluidity of that situation, that it will evolve clinically as it is doing now. There's an extraordinary difference across the country at the moment in terms of health and care services experience of what's going on. And it will vary for people personally as well. For me, I think the next thing then is providing some clarity on what the ask actually is, both during this phase and subsequently. It can't be all about COVID this time. We have to recognise that there are a chunk of other services that need to be preserved, that people need to feel safe in accessing those. And I think there is a danger that the sort of the outpouring of public gratitude towards those people who've been on the COVID front line does all sorts of strange things. I think it disenfranchises some groups of staff who are trying to deliver other services which are at least as necessary to continue. I think it creates an environment in which it can be quite difficult for people to say, do you know what, I've gone beyond what I can cope with. And we need to be able to set the balance to that and not allow that narrative to be the only one that comes through. And then finally, I think there's an acknowledgement that's needed from the top of the shop that actually this period needs to be a turning point for how we deliver health and care. If we don't take this as an opportunity to rethink how we do that for the future and rethink what our long-term ask is of people who work in the sector and what they need to support them to deliver something different, then we'll have missed an opportunity and we'll have a lot of people feeling that they've been broken for no good reason.
Thanks very much, Joe. Martin, can I come to you next? Best of times and the worst of times for general practice?
Yes, Chris. I think that's a good way of describing general practice. I mean, look at what general practice has achieved in the last 8 months, and I think it is truly remarkable. Basically, redesigned their services, shifted from practices, maybe less than 20% of practices providing triage to that being universal, from 80% of appointments being face-to-face to probably 70% being remote. We've seen general practices supporting COVID services, getting increasingly involved in post-COVID, long COVID services, in delivering business as usual. Other stuff hasn't gone away, of course, during the COVID crisis. And of course, planning and delivering the largest flu program we've ever seen. So general practice has done remarkable stuff. I could go on, but I won't, because there is another narrative, if you like, about general practice, which is a more critical one, which we're hearing, I guess, increasingly in the media. And is one which is demoralising to people who work in general practice. It's one that says GPs aren't doing what they used to do in the ways that they used to do it. The general practice is changing in ways that patients often don't like the look of. So general practice is changing. I think we need to be clear about that. We need to be clear to patients. We need to be clear to policymakers. We need to be clear to hospital and community colleagues as well. But I guess we need to be clear about which of these changes are good and which ones aren't. So let me look at the first area of where I think change is really important. So general practice is the branch of medicine which specialises in using trusting relationships between GPs and patients in order to get better outcomes. So we use our relationship with patients in the same way as a physician would use a drug or a surgeon would use an operation. There's strong evidence that patients who trust their GPs have got better experiences, they have better outcomes, and we know that resources are used more effectively. If, as is happening in general practice, particularly during the crisis, general practice becomes more transactional, less relational, less focused on relationships, then I think there's less time to build and utilize these trusting relationships, then patient care will suffer, and patient outcomes will suffer. And that's why in my college role, I'm going to continue to fight for reduced workload in general practice in order to create time for these trusting relationships to develop. And it's why we're going to continue to advocate for an appropriate balance between remote and face-to-face consultations, because face-to-face consultations are a really important element of building those relationships. There are areas, of course, where general practice is changing and should change. The GP, the expert medical generalist, won't in the future be all things to all people. We can see GPs are working as part of an expanded primary healthcare team, in which they're going to be focusing, if you like, on the two ends of the spectrum, on triage, because GPs are really good at making rapid decisions and managing risk, but also at the other end of the spectrum on complex biopsychosocial problems. So general practice will be both the front end and the most substantive part of the new integrated care partnerships that we're seeing as part of the design of the NHS. That's what's happened in the leading healthcare systems in the US and in Sweden. So general practice is going to be central to integrated care partnerships. And I think as we shift from our kind of GP as all things to all people role, we're going to be taking on new roles, which include, I think, a more substantive role around the health, not just of our individuals, but the health of our communities, a public health role, if you like, for general practice, in which the medical model that we're trained in is only used where it's clearly add value. And part of our role as GPs is to demedicalize much of the health problems that are presented to us. So general practice is changing in many ways. It's going to stay the same in many ways. And I think it's really important that we work together to support general practice, because it's so important to our collective aim to deliver a high value healthcare system.
What do you see as the path now back to a focus on more relationship based care? I mean, we are obviously still navigating this pandemic and infection control is kind of at the forefront of how colleagues are thinking about the delivery of services. But clearly you are advocating we need to get back there in the end. What do you think the steps are that are needed to take us from here to more of that relationship-based care?
Yeah, I think you're absolutely right, Hannah, that during this crisis, we have to understand and accept that healthcare will be more transactional. We have to get on, we have to prioritise, we have to deal with the stuff that's really essential, that probably care will be less patient-centred for a certain period of time. What do we need to do in order to get back to a relationship-based care, particularly in general practice where relationships are important? I think, first of all, some of it's in the hands of GPs. As I say, we can't see our jobs as being all things to all people in the future. We have to create space. We have to utilise the extensive skills that exist in the ever-expanding primary healthcare team. And that will allow us as GPs to focus on those with greatest need where relationships are most important. So we shift from this silly model in which the standard consultation is 10 minutes and that's kind of it, to a model in which we're much more flexible in the way that we use time. And a lot of the patients that I see in East London will need 20 minutes or even half an hour consultations, the kind of consultations that they provide routinely in Scandinavian countries. That's the nature of complex general practice that we're dealing with. So there's something about that. There's also something I think about having a much more mature dialogue with the public, with the patients and communities that we're serving, so that patients' expectations of general practice change. A lot of the criticisms that we're hearing, in the media, in the broadsheets, in particular, are from patients who want general practice to be like it's always been. They always want to see their GP all the time, for whatever problem they might have. And I kind of understand that, and as GPs we like that in some ways, but it's not the most effective use of limited resources. So there's something about us working with our communities to help them to understand this changing nature of healthcare, so that we use GP as the kind of rare resource that it is. And then finally, as an issue for policymakers, I don't think, with great respect to them, they don't understand the nature of relationships. They think general practice is a transactional thing. They don't understand how we use relationships in order to provide better care for our patients, in order to encourage patients not to use antibiotics when they're not necessary, not to have a specialist referral when that isn't necessary. That's all relational. Policymakers need to understand that. They need to take that message on board, so that the formation of relationships becomes a design feature of our healthcare system, rather than something extraordinary that can only happen in very rare circumstances.
Thanks, Martin. I guess I'm interested in just following up a bit. I mean, as Ben was reflecting, we're kind of heading back into the eye of the storm for a second time, and yet one of the things that everyone is reflecting on the kind of management of the first wave is just that there has to be a huge swathe of people who need to come forward for care who haven't done. And perhaps more relationship-based care would, entice and enable the identification of people who should be in the health system at the moment, getting some proactive care that at the moment are lost. CF's done some work on cancer. We're just doing some on cardiovascular, and I find that the stats worrying and shocking. So I guess I'm interested to know, what do you think general practice can do differently in support of trying to get people to come forward who really are still kind of standing back from entering the health service at the moment?
Yeah, this is such difficult territory, isn't it? I have to say I'm really pleased I'm a doctor and not a politician, because politicians are having to make these really difficult value judgments about the where we put our efforts. Do we put it into people who are acutely ill as a consequence of a potentially preventable infection, or do we put it into the long-term condition management, which is so important as well? We know that when the reviews of how we've responded to COVID take place, we know that the data will show that probably more people have died of non-COVID conditions as a consequence of the COVID pandemic than will die of COVID itself. And yet, what does that mean in practice to us right now as we move into the second wave? Do we allow people to die of COVID? of an acute infection when we could potentially prevent that from happening. I don't think we can do that or say that at the same time. And some of the dialogue that I'm hearing about the need to reset NHS services and get them back to normal, I think are pie in the sky as we shift into the second wave and have to deal with what is going to be probably as big or maybe a bigger crisis this winter as it was last spring. So I'm afraid I haven't answered your question, Hannah, and suggesting there are some really difficult political decisions that I guess we all need to be involved in. What can general practice do to help patients to come forward was your question. Well, actually, there's a lot that we can do, and we are trying to do it. We're trying to communicate more effectively with patients, particularly around cancer, symptoms that might be cancer, encouraging people to come forward. We know at the height of the crisis, there was a 70% reduction in patients coming forward for potential cancer services. That's now down to, I think, around about a 20% reduction, 25% reduction, something like that. So we're heading in the right direction. But most of the issue is about patients' willingness to come and see their GP to talk about symptoms that might be cancer. It's not our referral patterns. It's people's genuine fear of going into their hospital sector and picking up infections, or maybe just being a nuisance to the hospital sector, which they can see and hear is under pressure. So I think this is a big communication challenge, and I was really pleased to see NHS England putting out the public-facing campaign around supporting and encouraging patients to come forward. We're really supportive of it.
Hannah, can I chip in on this? Because I wanted to ask about whether greater differentiation within general practice as well as in hospitals would help us try and get that balance between responding to the needs of people who have COVID and the very important needs, as Martin has highlighted, of other patients who might go to the back of the queue. So practices did differentiation during COVID. Many hospitals in London did the same.
I think there are two aspects for me where the potential for greater differentiation plays in. Looking back over particularly the London experience in the first peak, what we saw was a real, just an extraordinary change in the way care was delivered. And a lot of the things that I was reflecting on when I was still in clinical practice and that have been the cornerstones of the work that we've been doing as CF over the course of the last 4 or 5 years actually suddenly came to pass. So conversations about shifting outpatient appointments, GP appointments to virtual, and that's something we've been struggling with to get people to say, yes, there is an opportunity here, and suddenly it's happened. Now, yes, some of it isn't right. And face-to-face is still really important, but we've demonstrated what can be done. And I think the risk for me in that is that we need to recognise that it's not right for everybody, as Martin's described. And if we can use the shift to a different mode of consultation for those patients for whom it is absolutely beneficial, and that the capacity that frees up can be then directed towards those who need more support, then I think we start getting into a different space. And yes, that probably does mean, GPs are all human beings as well. Actually, you will have different preferences in terms of how you work. And there has to be an opportunity through this and through the development of PCNs to say, some people are temperamentally more suited to non-face-to-face. We also know that there will be GPs who will need to continue to shield through the next period. How do we make best use of that as a resource as well? So there are opportunities in here if we're smart about how we make the working lives of staff fulfilling. We provide a more differentiated service to patients. I think one of the most striking stories for me was talking to an endocrinologist who said that their DNA rate for teenage type 1 diabetics had disappeared to 0 because they'd shoved all the consultations online. And of course, for that particular cohort of patients, it was kind of, yeah, absolutely, bring it on. We'll now start to engage with the service in a way that we've not done so before. Now, that really demonstrated for me the need to get that population segmentation right and the staff segmentation right so that you can align those two things together to work in a different way.
Yeah. And Ben?
And in answering, Ben, can you just also think about the question that's come up on the chat, which is actually what Joe's talking about is really tricky practically. to do both things at once. I think this is why Chris and I are going after this question of differentiation and how easy it is to do it in practice.
Yeah, so there's a really good question in the chat box, which I think from Simon, which summarises, I think, the key conundrum where you get to a point where we need to think about slowing the recovery of elective care because staffing won't allow one to ensure we're ready and right to prepare for the greater number of patients that will be receiving and sustain recovery of elective. And there are key professions there, like anaesthetics, where we really are going to be challenged at such crossroads, and they're finding that already in the northwest and northeast in bucket loads. I think the key things that we can do to help are, firstly, being much clearer that staff should be citizens of the NHS rather than an employer. And by that I mean we need to think about portability. So in London we have a new agreement where staff can work freely anywhere in the NHS at any site, regardless of their employer, and their liability arrangements are all signed off. And I hope that gives us a springboard to doing so much more, where we can truly move staff with their agreement to where patients need them. I think consolidation of hospital trusts will help in that regard, because I think we'll be more efficiently able to, economically able to release staff and organise care. And where we need to protect certain parts of the NHS to look after patients with particular needs more effectively, be that patients with long COVID, or patients with particular needs living in vulnerable communities. We really need to be focused on considerations around equality and equity as we do this. So I really do hope that we won't lose sight of some of the work that's been happening over the last few years to give more focus on inequality and equity. In London, we released the new workforce race equality strategy on Friday that we're really pleased about. It's a subject of engagement over the last 6 or 9 months, and it's really testing for the capital, and it sets up some really clear markers and innovative ways of thinking about equality through that work. I think finally we need to be really transparent. I would like us to be learning about the challenges we're facing much more quickly, not through the HSJ app or means where the media is commenting on where we're at, but by being much more open and honest about the limitations day to day of the care that we're providing across the systems we work. That engenders trust. We need to move beyond statements of assuring quality where we know in the back of our minds there may be an issue in a part of the NHS. And frankly, on a minute-to-minute, day-to-day basis, that changes, but it breeds honesty if we're that much more open.
Thanks, Ben. And while we've got you back and you've got the floor, I think I'm going to ask you the question that I wanted to ask you when we were about to lose you. So you said changing the subject onto workforce strategy now, but you said that no strategy was kind of helping people at the moment. And so I'm just keen to kind of tease out your thoughts in that regard. Obviously, much of workforce strategy was about addressing the substantial shortfalls there are in the workforce, and international recruitment was a kind of key part of the UK's overall strategy, or England's overall strategy, in addressing that in the middle of the global pandemic. Ethically, it's not really the right thing to be doing. So I'm interested to know what you are doing, what you think others should be thinking about in respect to the workforce more strategic agenda right now, and particularly different approaches to addressing workforce gaps, shortfalls.
Yeah, sure. So I think most workforce strategies in the last 2 decades, I'm an old hand, but in the last 20 years, they failed the fundamental test of a strategy. Strategy should be about making a choice. It's about choosing to do things and not choosing to do things. And what they've tended to be these massive piles of all the things you can think about in terms of workforce. And so they haven't, in my mind, made that choice about what you should focus on and what you shouldn't. Add to that the pandemic context, which means you need to be much more fleet of foot, adept in making choices day to day. So a strategic viewpoint of, say, 1, 5, 10 years ain't going to really work or help you either, possibly. So although things like the people plan, I think, help in giving a basis of how we can think about culture and organisational improvement in a positive way, some of the considerations around capacity need new types of thinking. The only thing I disagree on, I think, in what you're inferring, Hannah, is about international recruitment. I think the best and most advanced developed countries in the world rely upon bringing the very best into their country from wherever they're at into research and clinical roles. We've got a great history of doing that, and we need to rely upon it ever more. If you look at Germany, parts of the United States, even Emirates, they've got some Austria, Switzerland, France, really advanced thinking around international recruitment, academic alliances with countries abroad. And we're going to need the same. And I do think we need to return to international recruitment where it's safe to do so as quickly as we can, because frankly, things like the 50,000 nursing commitment and the growth we need in so many other key specialities will rely upon it. Even if we get the UK markets looking better in terms of supply and incentivizing more people in, that will take some time, particularly in more senior clinical roles. We're going to need to get the international recruitment flow working well for all concerned.
Thanks, Ben. I would have asked Martin what he thinks, but it looks like he's lost on the tech now. So we're just passing it around. Hopefully I won't be next. If you've got a question for the panel, please do put it into the chat. We're keen to ask them your questions as well as the ones that Chris and I have. So yeah, write them in the chat like Simon did, and we'll make sure to pick up on them. Joe, I was wondering if you look like you're going to come in with a perspective maybe on my last question.
Well, I was going to pick up the tail end of Simon's question in the chat, actually. So recognising, I was an anaesthetist for quite a long time and have been keeping in regular contact with my anaesthetic colleagues, and I know how difficult it's been, and I think perhaps one of the most emotional moments for me on the whole of the COVID saga was listening to Fergus Walsh interviewing Jim Down, who's one of Ben's guys, who Jim and I were trainees together back in sometime in the last century, and hearing the personal impact on people at the front line, and it has been extraordinarily tough. I had a conversation with an acute senior leader just as we were going into the pandemic, and I reflected at that point, I thought there was a risk that some people would be underutilised as we turned attention towards other key services, and that was very much the experience I had as a chief operating officer in times of crisis and in times of winter, and in the depths of winter, that some people actually weren't used as effectively as they could be, and that was deeply frustrating. And his concern actually was lack of management capacity to make full use of those people, because there is an opportunity through all of this, and we recognise where the constraints are, and we encourage people to do the things that they can do that are unconstrained. We have a massive outpatient backlog. We had it before we went into the first wave. We've still got it now. There's an opportunity to pull that ahead, so that at least when we come out of this, all those people who need an outpatient appointment have been seen. We've got a much clearer understanding of those who do need a surgical intervention, and we can then prioritise that appropriately and target the resource of that.
I want to change the topic, if I may, and I wanted to pick this up with Ben, but then pass to you, because he spoke about the diversity and inclusion report that has come out from his work in London this week. I guess it's kind of obvious that if we're talking about workforce issues on this panel, we do need to talk about the subject of diversity and inclusion. And perhaps we should all feel a bit uncomfortable doing it, seeing as we're a panel of white people, particularly, Ben included in that. And yet it is a key theme of what has happened through the pandemic and has brought it into sharp focus, uncomfortably sharp focus. The failings, I think, of the health and care sector in respect to, despite its values, in respect to the diversity and inclusion agenda. I'm interested to know how you see that playing out in general practice, the impact that it's had on staff, and what you would expect to see some of the step changes happen now over the coming period to try and address the inadequacies that I think COVID's really highlighted.
Yeah, it's a massive issue in general practice, as you can imagine, because we have such a diverse workforce. Just looking at GPs, around about 30% of GPs are from Black, Asian or minority ethnic communities. It's a higher proportion of that where I work in East London. We've seen massive problems with COVID in terms of the workforce as well as the general population. In the workforce, 11 of the 12 GPs who've died have been from Black, Asian and minority ethnic populations. So it is a massive challenge. And it's a challenge, I think, where there's been, quite reasonable and appropriate criticism of the way that we address diversity issues within the NHS. One of the ways in general practice that we're trying to address it, both from a workforce and from a patient point of view, is to make more effective use of risk assessment tools, which take BAME issues into account. The risk assessment tools at the moment are pretty blunt, but they're working on a much more sophisticated one in Oxford, led by Julia Hipsley-Cox, which I think will help us to identify people from Black, Asian and minority ethnic populations and identify their risk more effectively, and then allow us to target our interventions. And there's lots of things that we can do both for patients and for the workforce once we know what their risk is, and particularly in terms of remote working. So it's a massive issue for us in general practice as it is across the whole of the NHS.
Thanks, Martin. Ben, I don't know if you picked up the tail end of my question or got the gist of it from Martin's response. I was interested a little bit to know a bit more about the work that you alluded to on diversity and inclusion. I'm sure everyone else listening would like to as well. I remarked on actually the pandemic really bringing into sharp focus the need for the system to address long-standing issues of diversity and inclusion in respect to the workforce. And the white panel that's sitting in front of us all today, I think, is part of the uncomfort that's
it's telling, isn't it, again? So I think we need to move beyond the workforce race equality strategy and the associated strategies, and think more deeply about the causes of inequity and inequality, and being much more focused on a workforce sense around the needs of people on lower salaries. This goes back to something which Joe was saying at the start. We at UCLH had over 1,000 colleagues earning below £30,000 a year. And many of those colleagues had multiple jobs and caring responsibilities as care assistants during the day or night, but then in caring for people close to them, including older people and children during the day, often as single parents. And you've got to think about the employment solutions which meet their individual needs, rather than, again, starting from the typical refrain of employment policy that we're inheriting in the NHS that's been with us for 30, 40, 50 years in many respects, at least. I'm struck also with the fact that some of our terminology will need to move on. So there are parts of London where the majority of the workforce, say Imperial, is from Black and what we're calling minority ethnic backgrounds. And many employers are close to 45, 50% of their workforces being from BAME backgrounds. And we'll need to think much more perceptively about the relationship with the wider public sector, with general practice, primary care being at the forefront of this, and thinking about what truly makes an employer an anchor institution, what are truly the incentives and the modernisations we need to achieve to be at the leading edge of employer practice for such staff. I think those groups need more of a focus than perhaps some of those groups which we've devoted more attention to thinking about incentives for. So you think about the complexity and the incentives we've offered and enhancements we've offered to senior clinicians. They've taken much more time and conversation at board level often than the needs of people living in more vulnerable circumstances, working at the core of NHS care in all settings of care too. So I'd recommend Friday's launch of the London Workforce Race Equality Strategy. Take a look, tell us what you think. It's meant to be that new type of approach. It'd be great to get thoughts on it. If I can, going back to something else on Brexit, I was in a session earlier on today on Brexit. We've forgotten about it, haven't we, far too much? But it's that tangled web of COVID and Brexit and the economic position and the politics of this country, which will be an interesting context for 2021, whatever happens. And we owe it to people to simplify that really tangled web. But I'm struck again thinking about Brexit, that some of the implications of that in the earlier seminar were very similar to those we're discussing now, focusing on the low paid, value-based leadership, not suggesting or pretending that strategies will cut through, and reimagining the employment relationship. Those are common themes, I think.
It was great to have you with us today. Thank you very much for taking the last hour of your time out. Hopefully lots of interesting things for you to reflect on as we all grapple with this agenda going forward. It's definitely food for thought for me. Thank you.